Good evening, everyone, and thank you for attending this Artificial Intelligence in Vascular Surgery webinar. Before I introduce the program moderator, please note the Q&A button at the bottom of your screen. To submit a question to our presenters, click the button to open the Q&A window, type in your question, then click the Submit button. The moderators and other attendees will see your questions, and the moderators will select questions that will be answered by our presenters. The Q&A segment of tonight's webinar will occur at the conclusion of the fourth presentation, but we do encourage you to submit your questions at any time during the presentations. At the conclusion of today's program, we ask that you complete a brief post-event survey, as it will help the SVS section on outpatient and office vascular care to plan future web events. When the webinar concludes, please keep your browser window open and you will automatically see information about the survey. And now to begin the webinar, we welcome from Michigan State University, Dr. Judith Lin. Dr. Lin, the screen is yours.
Well, good evening and good afternoon, everyone, and welcome to our first Society for Vascular Surgery Health Information Technology webinar. This is on artificial intelligence in vascular surgery. Today, I have the distinct honor to co-moderate this session with Dr. Uwe Fischer, who is an assistant professor of surgery at Yale University School of Medicine. This SVS webinar is focused on the use of AI in vascular surgery, and we are joined today by 4 additional distinguished panelists with a variety of expertise in using AI technology. Our first speaker tonight is Dr. Sharon King, who is the Chief of Division of Vascular Surgery at Veterans Administration Loma Linda and an Associate Professor of Surgery at Loma Linda University School of Medicine. Sharon will present a brief overview of AI in vascular surgery. Our next speaker, Dr. David Karaguntla, is the founder and CEO of Alio, and Dave will bring us expertise in current application in AI technology and vascular surgery. Also joining us is Dr. Paula Shireman, who holds the Dielman Chair in Surgery Endowment. She is a tenured professor of surgery at the University of Texas Health San Antonio and the South Texas Veterans Healthcare System. Her grant uses machine learning to understand the effects of frailty, rurality, social risk factors, and care fragmentation on surgical outcomes. And Paula will discuss machine learning and policy in her talk. And lastly, our distinguished speaker, Dr. Alan Lumsden, is the Walter W. Founder III Presidential Distinguished Chair, DeBakey Heart and Vascular Center, and the chair of the Department of Cardiovascular Surgery at the Houston Methodist Hospital. He is also professor and chair of Houston Methodist Weill Cornell Medical College. And Alan will present the future of AI in vascular surgery. So without further ado, I will turn over the screen to our first speaker, Dr. King.
Hello, good afternoon and good evening. Thank you to Dr. Lin and the SVS HITC committee for this incredible opportunity. I have no disclosures. To start this talk, I want to review a few definitions and concepts. First is, what is artificial intelligence? And in general, AI, or artificial intelligence, it's a broad discipline that aims to understand and design systems that display properties of human intelligence. And by human intelligence, we include some of these things like reasoning, learning, adaptation, interaction, and sensory understanding. The goal is for AI to teach machines to learn from their experience, so that we're not actually teaching them and one-to-one inputting this, but they can actually develop higher order learning and develop these concepts. Within AI, which is just a discipline, there are subsets of AI, one of which we'll review is machine learning. So machine learning is, again, a subset of AI, and the concept is it allows the machine to learn and make predictions from the data that is entered and identify patterns, especially from raw data, without explicitly being programmed, right? So it's not we are controlling it step by step. The machine has data that's inputted and has an output. It analyzes its errors and just keeps doing it until it gets a better idea of what kind of output is more accurate. And buried within machine learning is actually deep learning. And deep learning is a subset of machine learning. It is an algorithm that has great flexibility. And the deep learning is a little bit more complex. It's got multiple layers that progressively is able to abstract concepts and make abstractions and then have an output that may be very different from the original raw data. And some things that are like being used for deep learning would include visual object recognition, for example, right? It mimics the visual cortex and it simulates the way it would recognize images. Now, we can't talk about deep learning or some of the more advanced forms of algorithms without talking about neural networks. And the two main types that I specifically want to talk about today are the convolutional neural network, or CNN, and then the artificial neural network, or ANN. Now, CNN and ANN are both buried within deep learning, and it is two slightly different ways to apply the usages depending on what kind of data is being analyzed. So CNN is applied for image processing, and it allows for detection, segmentation, or image segmentation, and recognition of objects and regions within images. It's multi-layered. There's a mathematical model simulating the properties of the visual cortex, right? So it's really an image-based utilization. Contrasting that with ANN, and you need to kind of think of this because it's inspired by the biological nervous system. So if you imagine in what I've written here, neurons that transmit electrical signals from one end to the other, then that one neuron connects to multiple other neurons, then connects with other more multiple neurons. And it creates an incredibly complex evolution of basically deep layers. And then it can process data that way. So a neural network, and then this is just a really quick definition, is just a computational learning system, right? And then we've divided into images, or let's say the neuronal system, that uses a network of functions to understand and translate data input of one form, and very often takes the original raw data and makes it into a different form of output. So this is just one very rudimentary depiction of, let's say, a convolutional neural network, where you see an input, which is a picture of a cat, right? But how do we understand that that's a cat? And that's what we want the machine to do as well. And so within this little rudimentary pictorial, you have multiple deeper layers that have different little convolutions, if you want to say, that eventually teaches the machine to understand that this is a cat. And the goal would be eventually, it's not just this one picture, it's pictures of different colors, different sizes, different shapes, all variations of a feline, a cat, and the machine will understand that that is what that is. Now, that brings us to where AI is in vascular surgery. And I can't really talk about that without talking about where AI is overall in medicine. And to talk about that in the large scale picture is to have a concept of big data. And that's where we're living right now. There's so much data between EMRs, the large clinical data registries for everything, healthcare information programs, all the way to the very small at the molecular level, the molecular gene expressions, right? So AI doesn't really differentiate, and it doesn't really limit us to analyze in the relationship of these things. So I think one important point that I've written here in bright yellow is that AI, right, allows us to have the potential ability to compute large and heterogeneous imaging and biomarker, seemingly unrelated things. Anyway, those data sets, and to identify patterns, even if their relationships are extremely complex and very evidently nonlinear. And AI allows us to incorporate these things. So one thing I kind of really want to touch on, and there's greater talks later on talking about applications of AI in vascular surgery, is where are some of the applications right now, right? What are the things that are being written about? And one thing that people have really enjoyed using AI for is vascular surgery imaging. And I've put two models, examples up here that's been talked about a lot is, the use of AI in the carotid, the anatomic wall modeling, and also the use of AI or convolutional neural networks in aortic disease, which has actually got great potential, right? Because if you imagine, if you can use AI or convolutional neural networks to talk and predict disease modeling or predictive behavior of the disease, or prediction of aortic aneurysm behavior, then you have a whole application of how to identify malignant, presentations in the future, how to identify high-risk patients, etc., and then also streamline the care that these patients require. And one thing that has been applied a lot to using this is image segmentation. And this has been very useful when you want to analyze complex aortic anatomy, for example. In reality, it's not limited to aortic anatomy, right? It can be used for any form of imaging. Now, just a brief blurb on image segmentation. Image segmentation is not a new concept, and it's not something only for artificial intelligence use. Image segmentation is just the process, laboriously so, of separating digital images into multiple sets of pixels. The pixels are then grouped and tagged, right? The ones have similar characteristics. And then you can use that to basically itemize with labeling of regions of interest or analysis sets of shapes, and then therefore create a 3D model, for example. And can be done manually, like I mentioned. It's not meant for specifically AI. So if you look at the picture of the tiger walking at the bottom of the screen, on your left, we see this, right? We see the tiger on the grass, next to a riverbed, next to a bunch of higher grass, and the different colors of orange and black, and also the areas of the sandy parts right in front of it. If we were to actually perform image segmentation manually, we would then transfer it to the image on the right, where we distinguish out borders, we distinguish out colors, we distinguish out the animal versus the background. But some things that are not done here that is much more complex and laborious is how to create the concept of the 3D, the layering of these images, right? We understand looking at this picture, the tiger is on the grass in front of the river, right? But when you look at the segmentation model here, it doesn't necessarily seem like that, right? So how do we translate all that complex processing that we can do automatically into a pixelated, objectified way? So one group that really wanted to take a look to see if manual segmentation and if automatic machine learning segmentation was even comparable, right? The idea that machines can do something good as us seemed very foreign at that time. So they chose to look at the carotid model. They wanted to take a look to see if the machine image segmentation technique was just as good as the manual segmentation technique to look at vessel wall morphology and see if they can quantify the degree of accuracy. So what they found was that overall, they showed that when we manually segmented, and there were complex ways that they had to do this with center line and how they chose to define the anatomy borders, and then when they asked the machine to it, they showed very good agreement between the manually and automatically determined contours, and that the distance was less than 1 pixel in terms of differentiation. And overall, this was a single center use and with a very small population, but they saw the potential, and that they saw that this ability had the, quote, capability of providing vessel wall delineation with high accuracy and limited the user interaction. Can also be interpreted as user error. And you can apply this to large-scale patient studies, and they felt that it could reduce image analysis time and reduce the bias between human observers. So they found that in their study, it was a very useful way to apply, especially into carotid morphology. Now, some of the more exciting things has been the use of image segmentation or convolutional neural networks in looking at aortic disease and aortic anatomy. And if we look at what has been published, looking at interactive CT segmentation by active learning. There's been reports about aortic aneurysm segmentation, regional statistical information, a fully automated pipeline for mining abdominal aortic aneurysm using image segmentation, or a quantitative 3D analysis, aortic size and neural calcifications. These have different studies throughout the time that have used convolutional neural networks or machine learning to see how well that they can identify and also teach the machine to better analyze aortic morphology. So we looked at these studies and opted to try to do the same thing. So several years ago, we developed our Loma Linda AI Core Lab. And we started with a very simple question, and which was our proof of concept study, which is, can we train a convolutional neural network binary classifier to detect abdominal aortic aneurysms on CT imaging? Very easy, right? The binary classifier, which is one of the simplest forms of machine learning. And this was, our convolutional neural network. And again, just as a quick recap, the premise of this CNN is that data is fed into the network, and coefficients at different levels of the network are predicted in order to generate an output. The error of that output is then estimated, and the cycle is iterated again and again in a cyclic loop in order to improve prediction. So this is just a pictorial of what that would look like. This is for analysis. We chose the VGG16 architecture model. Long story short, it is the model that we use to analyze our data, and then to boost the performance, we apply techniques like augmentation, transfer learning, and then also set model parameters in order to get the best output that we can. Without going to great detail, I just want to quickly show you what we found is, when in our study, these graphs basically demonstrate the performance of our model over epochs, or cycles of learning, if you want to think about it. On the left, you see that overall the error decreased over time, while the graph on the right demonstrates the accuracy as it continues to train over epochs, right? So in our way, with our augmentation setting, we were able to get the machine to accurately have an accuracy in performance. And here just is a quick pictorial to show you that the receiving area under the curve is excellent. It's at 0.99 and has an accuracy of 0.94 for both our training and validation subgroups. And this basically is just trying to say that our model, our proof of concept model, is sensitive and specific. And just to make sure we analyze it correctly and then arose at the proper accuracy, we generated what we call a confusion matrix, which in the clinical world is just a simple 2x2 table, right? So on the y-axis, you have the predicted label, on the x-axis, you have the ground truth label. And in this case, for example, in the binary classifier concept, we actually just looked at aneurysm versus none and saw if the machine was able to figure it out and learn from its mistakes and get better, and it did. And then where it erred, and with the confusion matrix, we can demonstrate that the most common error were false negatives. So what does this all mean? And I think there's some great talks coming up looking at the future, so I'm not going to belabor this. But with this new technology and the application of CNN, we have the ability to objectively break down image into a large biostatistical data set, for example. And this leads into something called AI and precision medicine. And precision medicine is this concept that we can provide the opportunity of personalized healthcare management to individual groups of patients based on large data sets, disease profiles, diagnostic or prognostic information, and treatment responses. And with the merging of clinical biomarkers and imaging data sets, we can develop a more personalized therapeutic management for very complex patient populations. That is all I have. And thank you so much for listening to a brief intro, and I hope some of this was helpful.
Thanks, Dr. King. And let's now move on to the next panelist. It's Dr. Korogantla, and he's going to talk about current application of AI technology in vascular.
Thanks, Dr. Fisher. Thanks, Dr. Lin, for the opportunity to share a little bit on where some really exciting opportunities in AI and vascular surgery are today. As Dr. King kind of mentioned, there's a pretty interesting opportunity right now in terms of imaging and where that is utilized today to be able to both reconstruct and build new images and make them more valuable for everyone to be able to see what is actually happening. And then also from the standpoint of being able to then diagnose what's happening to the patient. So taking it from clear images to the actual diagnosis of the image, a lot has been spent in that arena, and you may be very familiar with that. But I think that the utilization of that is accelerating, because a little bit of the problem maybe perhaps in vascular is how many images are we actually getting? Are we getting enough? Does that allow us to actually create an AI model? Because AI models need lots of data. So wherever increasing data lies is in that EHR, being able to look on some of those different biomarkers that are not image-based. But does that allow vascular surgery to actually be a little bit more predictive about when something is happening for a patient, and if they can do something and intervene earlier before imaging can even happen? And I think there's some interesting articles and recent publications and posters on where that's happening today that leverage some different forms of AI, and we'll walk through how they're doing that. And last but not least, I think something where, as was mentioned earlier, co-founder and CEO of Aleo, but there are a lot of interesting non-invasive biomarkers for early warning that are leveraging really unique AI techniques to actually push the arena even further forward to get that imaging, before the ER, being able to get actual early warning systems based on what's actually happening to the patient. And we'll pull back the curtain a little bit and talk about what's happening there as well. So from the standpoint of actually looking at some of the way that the reconstruction is happening for the imaging here. So Canon released an interesting product that was around if they could utilize a 1.5T MR to have the same image as a 3T MR, and if they could utilize AI to bridge the gap between the visualization. So they trained the system on a convolutional neural network, as we just learned about, and allowed them to see that they could do faster visualization, remove a lot of the excess noise with much lower cost machines that were potentially beneficial to the patient as well. So where do they start, and where does a lot of AI start? A lot of AI is quite, it's not as automated as you may think it is, right? It's pushing lots of data into the system. So initial training, they had to be very selective. They actually selected a lot of high signal to noise reconstructed MR images that allowed the system, the AI system, to actually understand what real truth is. Something I heard once a long time ago was, how do bank tellers, when in the days when we used to use cash, how do they know what was actually a real dollar bill versus a counterfeit dollar bill? Was by actually feeling a real dollar bill over and over and over again. That way, when you know what good is, you can figure out what's actually fake. And so that's a similar system here. You gotta feed the system good. You cannot feed it garbage, otherwise it's gonna come out with something bad. So that allowed them to distinguish the real true signal from noise, and then start to build a system where you maintain that spatial resolution and low noise. But then you have to really find images that are different. Now you have to start feeding something in the system that looks a little bit different to actually enable that performance. And last but not least, humans are still really important, because the validation of whether or not that was a good AI system did require a cross-disciplinary team from radiologists, AI engineers, other clinicians involved as well, to make sure that everyone understood whether or not this actually represented where they wanted to be. And as they moved into the operational phase, they realized they were only going to feed low quality data. And if the neural network could actually reconstruct that into a high signal to noise system, and if the high quality target couldn't have already been fed into the system previous, it had to be completely naive and then validated by the team that it was very useful in detecting that noise and removing it from the image. So if we can utilize AI to reconstruct images, how do we move that into care? So VizAI has been doing this for a few years in the neuro space. Recently, I believe they launched a product called Viz Aortic, I believe. And so in addition to being able to see the image on a phone, they're pushing that a little bit further forward into being able to look between type A and type B dissection detections, being able to actually visualize the true and false lumen, and then also being able to build in some of the care coordination. So moving once again from cleaner imaging to actually leveraging that imaging into faster diagnosis and care coordination is where AI is being utilized today. So this isn't necessarily what VizAI does, but there was a paper from last year around actually detecting the true versus false lumen and kind of walking through the steps of how they did this. And I thought that might be an interesting thing for us to walk through today as well, from a true versus false lumen detection here. So first, they took the image, they segmented the entire aorta into an axial slice, what they call the ALO algorithm. Then they took in the aortic volume to figure out where the center line actually was, which they call a CEN algorithm. And then last, they actually took the and reformed it in a multiplanar way with an orthogonal image to figure out what the true and false lumen is, and then actually pull that all together to be able to segment what was true, what was false, and then finally present that image back to the clinician in the traditional axial plane, while now knowing what the true versus false lumen actually is. Once again, being able to train this means much higher accuracy and much higher precision as well. So I mentioned, I think there's a lot that's been going on in the imaging space. You might be familiar with it already, but there's also a lot of interesting ideas that are about how do we take these models and classify things earlier. One of them was utilizing a machine learning model to classify the dissection early diagnosis. A large percentage can be misdiagnosed in terms of searing chest pain, and while we're waiting for the imaging, wanting to figure out which attributes actually were valuable and potentially being predictive before the imaging even happened. So they looked at a series of attributes. They took out all the attributes in the EHR that were not actually attributable to all patients, such as their occupation or what they might have done. Then they utilized what's called a correlation-based feature selection. So which features actually had any correlation at all in terms of being able to be predictive about an aortic dissection versus not, and then selected I think they narrowed it down to about 40 in the first instance, and then the second they narrowed it down to about 13 attributes that actually had a good predictive ability with the lowest degree of redundancy about what was actually valuable for classifying the aortic dissection before imaging even occurred. And they utilized the Bayesian network model, so they had a prediction precision rate of almost 85%, and they error curve 0.87. So pretty well from a precision of whether or not the patient had an aortic dissection before that imaging even occurred. And so Bayesian networks are really good at taking the event and looking at what within those potential known causes was actually the contributing factor. They're very good at pulling that up to the top and then analyzing that back into the system. Another recent poster was on whether or not AV fistulas were failing. So this is a single center study looking at about 117 fistulas. They had already done a look at this in terms of just looking at the traditional things, look at in terms of age and vein diameters, whether or not they're predictive factors. They actually utilize what's called a random forest model, which is a series of uncorrelated decision trees to actually go back and look at the data again, and they added in a lot more things that they knew about the patient, including full ultrasound mapping, the comorbidities of the patient, laboratory, full CMP, and other laboratory data as well. And what they realize is now they could be very accurate, very precise about which fistulas were likely to fail early. Interestingly, the most relevant features were not what you may think they would be. They were actually age, phosphorus, PTH, ferritin, and calcium were actually the most relevant, and the least relevant or of minor relevance were actually perhaps the more traditional ones of vessel diameter, peak systolic velocity, etc. And so by taking that into a random forest model, the benefit as well is by having these uncorrelated decision trees with layers, the prediction is by committee rather than actually following a single decision tree in one direction, which can confound the data. So you actually get a little bit more of a committee approach, which in this instance is actually useful. Likewise, another study looking in the carotid space about characterizing plaque for stable versus unstable plaque, looking at if in the imaging there was more scattered rather than in the symptomatic plaque was more scattered. And they looked at multiple different models. What was interesting is all of those models had at least a mean accuracy of almost 90%. Some were more accurate, but being able to actually utilize any model with AI was actually better than being able to just look at the image. Once again, looking at something like AKI after surgery. So taking the traditional ASA classification for the patient, pushing it forward to include both pre-operative, intraoperative, and potentially even some post-operative data, pulling it continuously together. And while there may have been some confounds along the way, still getting that data outside of the traditional classification, physical status classification, and adding in both pre- and intraoperative data, and perioperative data was the best way to understand whether or not the patient was likely to have AKI post-surgery. And AI allows us to not rely on different clinicians or different care providers in different settings all working together from that care team, but being able to systematically look at the EHR as it's filled through the patient's journey and being able to ride as a layer on top to be predictive about injury. Another one is also in terms of real-time stroke risk. So very traditional clinical risk models, and they, even for all of us to remember, some of them have 18, 20, 30 risk stratification tools. They're all very different. But instead, they looked at what was called a clinical multimorbid index. And so looking at whether or not all the different pieces together, which ones mattered most for that specific patient, they realized that instead of looking for one key feature, looking at multiple key features that were relative to the patient could actually reduce that individual's stroke risk as well. So this is a pretty exciting area of development in terms of how do we get non-imaging data, pull it all together, what's useful, what's not, to actually help benefit the patient. And there's multiple different AI models that can be utilized in different ways. And so picking the right one is certainly very, very important and requires a cross-disciplinary team, once again, to figure out how to best improve the patient. Last but not least, I think the really exciting area of AI is going even further, a layer even further down. And so one of our partners is the NHS, and they've been utilizing dialysis patient monitoring by actually sending nurses about 50 miles each way to get a blood draw from the patient for things like hemoglobin hematocrit, potassium, et cetera. They realized they could reduce their hospitalizations and the visits, but obviously it's a very expensive way to utilize that. And so we had an opportunity to work with some doctors there, and we said, okay, we can do one of the things that you care about, which is H&H. Obviously, that's been from a non-invasive way for quite some time, but is there a potential to do potassium as well, non-invasively? And how we, as you kind of pull the curtain back a little bit without giving too much away, the way that we built that out was what was interesting about potassium and its correlation to other metrics within the patient. Was there ground truth from a blood draw or a point of care test that could be pulled into the AI model as well? The benefit of being able to get raw data and raw spectrum if you're utilizing any sort of sensing modality, rather than having that processing already being done before you get to your AI model. Having all that available to you meant that you could start to look at the ground truth, how it changed. Finding high signal to noise is important. So dialysis patients pre and post dialysis session will have a large change in potassium. So ideal patient population. Then looking at what was likely to be correlative, either inversely correlative or proportionate as well. And then looking in that raw spectrum, being able to have access to that and having your AI system have a feature detection to find where in that raw spectrum something was similar by putting I think about several thousand data points, being able to build that algorithm for potassium, and now pushing into further metrics where in some cases getting 1 million data points is proving to be required to build the underlying algorithm for zero calibration, point of care, non-invasive metrics that can be utilized further to diagnose arrhythmias and sudden cardiac death, stenosis and changes in volumetric flow, all non-invasively without requiring many of the imaging modalities and others that are utilized today. So certainly very excited about where we can take this in the future. The AI technology at multiple layers in vascular surgery is going to be really exciting, from basic science to all the way to predictive biomarkers for diagnosis, and then really leveraging that imaging to build into care coordination for the physicians as well. It's going to be very exciting. So thanks again for your time, and looking forward to answering your questions later.
Okay, thank you very much, Dr. Karagantala. And now let's see what Dr. Shireman informs us about machine learning and policy in vascular care.
Thank you, Dr. Fisher. Machine learning and policy is obviously what's happened in, it's very usual within medicine and other industries, is that our technology very rapidly outpaces our ability to regulate, understand, control the technology. And that's why this becomes a relatively interesting area of what we can do right now and what's possible and how we can use this in the future. All right, I just have research grants as disclosures. So there's lots of challenges to developing algorithms. And you've seen a lot of talks now that have been predominantly on imaging. And imaging is much cleaner in the sense than it is, say, in electronic healthcare record data. There are huge data quality issues that are common in electronic healthcare record data, such as misclassifications and also incomplete data. One of the things that if you look at the literature, multiple algorithms are often developed on a single institution. And essentially that means you have incomplete data. We may think a patient had a wonderful outcome, but they went down to the next hospital and got admitted to the emergency room there. And then truly, a single institution may not be truly big data when we're talking about the vast amounts of data that are needed to really develop ML algorithms. So then people will often develop ML algorithms on claims data because that's very big data. It goes across multiple states, highly geographically diverse. However, claims data lacks the granularity of electronic health record data, as well as differences in coding. Certainly the safety net hospitals are shown not to code as well as private hospitals, so their severity of illness is lower. So the variation in coding and quality and all of that in claims data can often create difficulties. And then, of course, there's the whole idea of algorithms due to differences in patient population. So an algorithm that's working perfectly well in one hospital system may not perform very well in another due to different patient demographics, populations, and other things that are different between health systems. And then, of course, all these algorithms are usually developed in an ideal world rather than real world environments. And there have been certainly multiple media releases and articles, especially in the radiology and the imaging field, about how the AI did better than the radiologists and did this and did that. And you get these wonderfully accurate algorithms, and they work very well in that scenario. And then when they're moved into a real world situation, are not nearly as accurate. So even if we have an algorithm developed, there are huge challenges to clinical implementation. And so it really does require clinical validation in assessing algorithm performance in multiple real world settings. And once again, an algorithm developed in one setting may not perform well in another one. And then there's also the idea of establishing trust by providers and patients. As a lot of the algorithms are, as they call, black box, we don't really know what factors they're using to make their predictions. Providers and patients need to be able to trust the output. And then, of course, it needs to be user-friendly, interpretable, and actionable. And actionable, I think, is incredibly important. I was at a conference where there were a lot of ML people and some clinicians, and they were talking about actionable data, such as a primary care doc being in a clinic treating a patient with diabetes, type 2 diabetes who's overweight. And the actionable suggestion was have the patient lose weight. So many of the things are really quite obvious, but can ML and these algorithms actually provide actionable data that's useful to clinicians that isn't obvious? And then I think a very big challenge is integration into clinical workflows. Even if you have an app on your smartphone, if you want to document it in an electronic health record, how many platforms do you have to switch to? And so really working these algorithms into clinical workflows can be quite challenging. And then, of course, there are also ethical and legal issues. Patient privacy and use of data for algorithm development. Patients obviously are having their data for their own healthcare, and then to use that data to develop algorithms, there are questions about whether that's appropriate, who owns the data, should companies take patient data and make products that they can make money. All of these are, ethical issues that are, currently being discussed. Unfortunately, healthcare disparities can be propagated by ML algorithms, and that's often the case when the data sets have low representations of minorities. And a minority can be in multiple different senses. So low numbers and low representation usually leads to predictions that are either overfit or not accurate. And then, of course, black box algorithms really lack explanation for predictions and recommendations. And that is a difficult part when we really don't know what factors the algorithm is pulling together to make its prediction. One of the things that I think FDA really has to wrestle with is approval of potentially continuously learning algorithms. One of the great strengths of machine learning and AI is the ability for these machines and the algorithms to get better and better. And let's say that an algorithm was developed in one hospital system, it could learn in a different hospital system and get better. But how do you regulate something that is constantly changing? You know, when we have a drug, we know exactly what's in the formulary and the formulation of that pill. You know, and so how do you regulate constantly learning algorithms? Or do you say this algorithm has to say as is, which obviously is maybe not the greatest for algorithm development and for implementation. And every so often we have to help it relearn and then revalidate it. So it becomes very difficult when we think about how does FDA actually regulate ML algorithms. And then, of course, there's the legal issues of liability for a wrong algorithm output. Who's responsible for that? Is it the clinician or is it the algorithm developer? So there are multiple examples of AI algorithms, and as the two prior talks have kind of shown, the vast majority of the algorithms that are currently used in medicine are for imaging. And this website here has a list of all FDA cleared imaging algorithms, and it's kept up to date. The reason that most algorithms are developed for image analysis is that they can use supervised learning and that you can annotate all of those images by an expert, a radiologist, or some other type of clinician who says this is what we call ground truth. You've heard that used in multiple times. This is a true outcome. And that's how the algorithm learns. Last week, we had hot off the press an announcement, and you heard about that with pulmonary embolism and aortic dissection. It is primarily imaging, yet it is also then using the imaging and the analysis to hopefully alert clinicians and maybe increase the speed of care for some of these patients who may have very time-sensitive diseases and disease processes. Another example of a clinically applied algorithm is Sepsis Watch that Duke Health has applied within their hospital system. And then, you know, pertinent to the pandemic and all sorts of things that have happened in the last year and a half, there's Health Map, which essentially has a global view of infectious diseases and threats. So as you can see, there's lots of challenges for how, not only how do you create a reliable algorithm, but also once created, how is it implemented? How do you accommodate the real learning, the transportability and transfer learning into different systems? And of course, the legal issues of who is responsible if something goes wrong with that algorithm. And so these are the references from this talk. And thank you very much.
Great, thank you, Dr. Sharma. And now let's go to our last speaker. It's Dr. Lumsden, and he will talk to us about the future of AI in vascular surgery.
Well, thank you, Dr. Fisher and Dr. Lin, for the invitation. I think when I got this invitation, I realized how shallow the bench strength must be in the vascular surgery world about AI, because I certainly do not consider myself an expert. I'm going to talk about 4 different topics, topics that I've been involved in at various different levels. And I can't say that I understand basically how AI works, but neither do I understand how an MRI scanner or a CT scanner works. But I need to know enough about it that I can figure out how I utilize it in my clinical practice and how I utilize it to be able to change the way I'm intervening on a particular patient. So I'm going to talk about 4 topics. I'm probably going to briefly talk about imaging because we've talked about it fairly extensively. Another is on organ allocation, surgical instrument optimization, and autonomous transcranial Doppler search algorithms from a company called Novasignal. So these are my disclosures for 2 of these different companies that we're involved in. So I'm going to ad lib a little bit since a lot of this really has already been covered. I've been interested in imaging for a long time. He who controls the imaging controls the diagnosis. He who controls the diagnosis only can control the referral patterns and how the primary intervention is going to be determined. And so I think it's extremely important that we remain involved in imaging. And these algorithms can help us in a variety of different ways. So since we've talked really about how AI can actually track, for example, aortic disease, let's talk a little bit about how we can go to a different level and how this actually works. In order for these algorithms to work, you got to have certain readily identifiable landmarks. And when you think about it, they're not necessarily all vascular. Bronchial bifurcation is an example. Where the supraortic trunks come off is another example. The shapes of the kidneys are another example, and what the pelvic bones look like. These are the kind of things that the data that is fairly consistent from one patient to another and can be used really to drive the data input to develop these algorithms. And this is one of the references that if you want to go into a deep level of how this is actually created. And so, of course, what we're interested in at the end of the day basically is how reliable this actually is. And these are the process. So, for example, lung nodule identification is another example. Ultimately, these are the things which have largely been touched on. Where does the data come from? How basically was it annotated? Is it complete? Is it reliable? What are the variables that can affect the image quality? And basically, ultimately, how effective these algorithms actually are and how it can be updated. So we've largely talked about a lot of this stuff. What we've been interested in basically is how we pull out these wire mesh depictions, the segmentation of the vascular tree, and not just the aorta basically, but the branches that are associated with it. And this is one of the things we were involved with Siemens is these automatic identification patterns that help drive segmentation for EVAR planning. And when you think about it, they need our input in order to be able to do that. What is important? And when you start helping build these algorithms, you suddenly find what you really need to know. You need to know where the lowest renal artery is. You need to know where the bifurcation is. And you need to know where the internal iliac arteries are. And that input is important for them to be able to build these algorithms and then test and update the efficacy of these algorithms. What we're also interested in are some of these center lines. This is going to let these rotate while I'm talking about it. What's important is, the center line we were particularly interested in, and this is the center line of both the renal arteries and the aorta. These can all be described in XYZ coordinates. And these XYZ coordinates we've been particularly interested in because it can be used to drive the movement of a robotic catheter. When you drive a catheter up and over the aortic arch, we talk about navigating, but we really don't navigate anything. We depend upon a series of wall interactions to move these catheters. And if we can actually define the aortic mesh, we can define basically what that center line is, and we can input that data element into a robot, and assuming that the fusion is accurate, then you can potentially, and this has actually already been done, have autonomous movement of robotic catheters without them touching the walls. And this is the importance of us being engaged and understanding what this data can actually be used for basically as we move forward really into the future. So I'm going to leave imaging behind and look a little bit about how we can actually use this to optimize patient selection. We've heard a little bit about that previously, but this is from a company called InformAI. It's part of an NSF grant that we at Methodist and Baylor College of Medicine were involved in. And it's all about trying to optimize the match between the donor and the recipient of these organs. And there's huge, of course, need for that. There's a lot of data we don't need to dwell on since we're going a little bit late. But essentially, the transplant AI algorithm, and you could potentially do this for selecting patients basically for other therapy. But essentially, by looking at the input data, looking at the patient who comes up first in the wait list, are they optimized for that particular organ to be transplanted in that patient? And then basically by creating these prediction analyses, It may not be a patient who's waitlist number 1 who's going to be selected because they're not the optimal donor. And it may be that we can improve graft survival, organ survival by moving down into a more appropriate patient. So imaging is certainly an application. I call it applied or interventional imaging, where we can use that data to actually treat these patients. And optimization for recipients in a transplant world is another example. A much more closer to home example is from a company called MS Biotics. What they're trying to do is basically make our surgical field a little bit more intuitive, autonomous, with feedback basically on our instrument utilization. And again, we know that there are a lot of instruments that are open that don't get utilized, that there's a huge amount of time spent in an operating room, and every minute is money when you're in an operating room. Can we improve our understanding of which instruments are necessary to utilize? And the way that this is actually done, we're trying to figure out what instruments are not utilized. The way this was actually done is put RFID chips into each of the instruments. They're tiny. Here's an example basically of what they look like. The table basically is a detector, creates this RFID field. It can actually count all of the instruments autonomously. The RFID chip is shown based in the bottom left-hand corner here. It's small, would be applied to each of the instruments. And it allows you basically to actually measure which instruments are utilized. This is the test setup where this has been proven. It was initially developed in orthopedics, then in cardiac surgery, and now we're actually working with them around the vascular surgery world. You can automatically tabulate which instruments are on the field, which instruments should be on the field at the end of the case, hopefully, and what the utilization of these actually were during the course of the operation. And what that then allows you to do basically is to drive basically AI algorithms to make suggestions about which instruments are necessary, which could be on a secondary pan, and to streamline this and make it a much more customized instrument set. Because we know that our nurses tend to over-open the instruments because they're afraid that Dr. Fisher is going to shout at them, for example, if they don't have the instruments they want at a particular time. And so this is a way basically of trying to quantitate very accurately, giving you that feedback and try to basically make it a little bit more intuitive about which instruments should basically be on the field. Now, lastly, the one I've been most closely involved in, this is my operating room. We got a bunch of robots in there. The one I'm going to talk about is a robot which is used for transcranial Doppler. Now, I've been very interested in transcranial Doppler, continue to believe it's the best way of monitoring the cerebral circulation because it's the only thing that actually tells you about embolization. But it's been very limited by the availability of experts to apply these probes in the temporal area and to pick up the middle cerebral artery signal. And so what this robot does is essentially does it autonomously. And so there's a head frame basically which is put on there. It searches on its own to pick up that signal, then it optimizes the signal. And this is done, of course, you can never basically get away from anesthesiologists basically who can make mockery out of any technology that we're developing. That's the head frame. But essentially it can either be done manually or it can be done autonomously. Those search patterns for that robot basically are all recorded. And this is used basically for machine learning to improve the accuracy basically of these search patterns. And so what we're trying to do basically is optimize this so that many people have more access to this kind of technology than are currently available because of the limited amount of expertise. And so this allows us basically optimize those search patterns. We've tested it, against a manually placed robot. It is as fast, if not a little faster, and produces a better signal. And so here's a method by which we think that we can improve the intraoperative monitoring capability and generalize it, getting around the fact that this level of expertise is not necessarily available. So in summary, I think there's huge applications in imaging. Again, I would say that you don't need to understand AI, but you do need to understand some of the applications of it. I think it's going to transform how we can select patients in a variety of different fields. I've shown you evidence of instrument tracking and optimization. That's a fairly fast track to approval, and how it can also be used for autonomous intraoperative monitoring. We've not even touched today basically on the virtual ICU and the amount of data that can be used basically to transform how we monitor it and how we get early alerts from our ICU. So thank you again really for the opportunity to present this from a user standpoint, somebody who's not really an expert in this field. Thank you.
Wow, that was great, Dr. Lumsden. A lot of exciting applications coming up in vascular surgery in terms of AIs and robotics and all the imaging and stuff. So we're going to go on for the question and answer portion. And this first question sounds like it's for Dr. Shireman. Are there strategies, this is from Adam Johnson, are there strategies to get good clinical data for use of developing machine learning for clinical predictions? I think one of the things we worry about is like ethics and the algorithm that you mentioned, and how do you sort of minimize bias? Dr. Shireman?
There are multiple ways of doing it. One is to actually apply clinical rules, and so those are being developed. They're like in the 6,000 or so range at this point in time, and I was actually typing an answer to that, so there'll be some references in the chat or in the question and answer where the data can be run over these rules, and they will identify like physically impossible values, and that can clean it up. However, you know, that only goes so far, and if it's a plausible value, it certainly could still be in your data set and still be very wrong. Other ways is once you have the ML algorithm developed, or at least the data set, you can actually intentionally perturb the data. So in other words, intentionally put errors into your data to try to figure out what the effect on the ML algorithm was. And so there's lots of different ways of at least testing that, to understanding how data errors can affect your algorithm. But it's a very rapidly evolving field with multiple techniques coming up, you know, to try to mitigate bias as well as, you know, avoid overfitting the data and all the other errors that are very common to ML algorithms.
Okay. Thank you, Judith. I'm reading a here for Dr. Korogantula. Can you talk a bit about how explainable AI and how vascular surgeons can oversee machine learning predictions?
Sure. I think there's also, I think Lauren also had a kind of a question around, you know, kind of where folks are involved, and I was kind of dropping some links into the answer as well too. But I think if I look at explainable AI, it's very much in, you may have heard of kind of the no-code revolution on Silicon Valley, right? So you don't need to know how to code to build. And I think that's kind of where explainable AI is heading, which is, do I need to understand every single aspect of the AI model, or in terms of being able to know what the difference between, if you have a random forest model, that this is just a decision tree, and we said that you're not picking a certain one, you just know that it's a correlation amongst those trees. Is that enough for the vascular surgeon to understand at a very high level which models can be utilized, and then apply those models to a raw set of data without having to actually build in all the feature selection to each one of those pieces? I think that'll be where the surgeons can get involved, I think, is actually in that feature selection. So I think less about understanding how to code, knowing what to do, knowing all of the models. That's not actually the important feature. I think even Dr. Lumsden kind of mentioned, you know, knowing where your hip bones are on an image is actually being able to very accurately identify that means you know where you are on the anatomy. So similarly, if you know what the most, potentially what the most meaningful item is within a set of clinical or physical attributes in a patient's history or chart, or in their trend line progression of their disease, what is the biggest indicator? Being able to explain that concisely to an AI team is where they can start to hone in on what to potentially look at. And I think that's really the value of the vascular surgeons up front in feature selection, and at the back end, does this make clinical sense or not? I don't think they have to be as involved in the middle of not understanding everything the team is doing, but I think that's where explainable AI can help in the middle of, can I drag and drop different AI models into the raw data that I have? And I think we're heading in that direction here over the next couple of years.
Great. So our next question is from Nathan Leon. And he says, as supervised learning methods get more complex, it might be harder for peer reviewers that are vascular but not methodological experts to review. So would it be beneficial for the SVS to come up with some kind of reporting standards, or adopt an existing one to guide both peer reviewers and researchers? Okay, that's a loaded question. I have actually been working with the SVS, appropriate use criteria. This is more on claudication, and I can probably answer this one. For the past year, we're working with Anthem to try to develop AI algorithms for their 6 million users, patients panels. So you're exactly right. It's basically, it's really hard when it comes to AI algorithms, and it's a whole team of AI plus clinicians to go through. And one of the things that we wanted to do is, can we adapt? There's different things. One is to diagnose people early for PADs using AI, sort of screen through the 6 million charts. The other is how do we sort of help clinicians make the appropriate referrals, especially pre-CPs going into vascular surgeon using SPS guideline. And then the last one is perhaps helping vascular surgeons, popping up with clinical guidelines. So it is still very, very early stages. So stay tuned on that. And yes, we are working on it, but it's a pretty big project. So first topic is really the PAD is the one. So Ube, you want to take this next one?
Yeah, so it's Thomas Forbes. It's directed to Dr. Lumpton. You touched on opportunities for augmented therapeutics in the OR or cath lab. Can you comment on further opportunities for augmented surgery to make procedures safer, faster, etc.?
Yeah, so another great question. Again, the CAT scan, think of it as the patient's universe. That's the way I think about it. And the CAT scan that you look at in the office is every piece of information you probably need to plan that operation. And so the way we kind of think of it is that is the guidance system. We just got to figure out how we take it in the operating room and how we fuse it on top of the patient. And there's a number of different ways: optical fusion, biplanar imaging fusion. And then basically we can interact with that in the operating room. The way that we've done recently is you can pull it in a HoloLens. You can actually wear a HoloLens. You can actually overlay that and that on top of a patient. Let's say you're going to do an open surgical operation without even the presence basically of a hybrid room. So you will live in the future of image fusion and taking these big data sets and importing them and overlaying them on top of the patient. Now, that's not the same thing, obviously, as AI. There's another question here from Dr. Ghosh about the EVAR project, and it kind of dovetails with the answer to this. A lot of these robotic catheters, they started off in the EP world, and they had built-in pressure sensors and built into them. So you could actually measure any kind of pressure that was applied to the walls. But what you really do with them, and this applies to all of the surgical robots, you're going to be able to lockout zones where you could draw, let's say, a centimeter around the inner surface of the aorta and prevent the robot from going into that space. So that's kind of the way that we're going to interface robotics basically with the imaging.
Okay, so next one from Shiv, Dr. Nykum, it's for Dr. Shireman. As more and more AI algorithms start entering clinical decision-making, do we suspect more clinicians would prefer relying on an AI-based cue than consider a choice contradictory to that of AI? Should we be afraid of involution of organic intelligence in the environment of progressive AI availability?
Well, I think some of our organic intelligence has already been maybe devoluted, if you will, just using cell phones and looking things up and all of that, which certainly has its advantages. I think it'll depend upon the clinician. There are going to be clinicians who are going to be early adopters and eagerly grab onto AI algorithms, and then there are going to be, like any other type of innovation, clinicians that are lower, that are very slow and maybe never adopt any type of an AI algorithm. I think really what's going to happen is that AI is going to be in the background, and that's actually what's happened in a lot of businesses. You as the business person, you don't even know that AI is happening in and around you, and that I think becomes maybe a bit more of the interesting aspect in medicine as to who is going to be responsible for that. I think there are so many things that AI could do to reduce cognitive load. I mean, I can vouch that when I get in front of my Epic EHR and there's 1,000 notes, and which one can I pick and where is the data that I really care about? Really, wouldn't AI be wonderful if they knew what a vascular surgeon was interested in and they provided it to me, and they knew what a primary care doc was and they provided it to them, and that all that data just came to you without picking through 100 notes that you don't have time to pick through. So it's going to be a slow evolution. And if you think about it, most of the AI that's really been used clinically is very focused. It's on acute kidney injury. It's on sepsis. It's not very global when we think about what's happening with the patient. I mean, you know, when we're clinicians making decisions, we're thinking much more globally than pretty much all of the AI packages that are out there now. So probably not in my lifetime, but maybe in some medical student's lifetime, there may be the talking computer that tells everybody what to do and we just do it. But I think that's a very, very long time in coming.
Okay, this next one is a loaded question from Dr. Alami and for Dr. Kiragupta, or basically everybody. So maybe Dr. Kang can talk about, when thinking about implementation, how important is it integration into workflow? Yeah, this is good for Sharon. You want to take this one, Dr. Kang?
Hi. Thank you for the question. I think, you know, there's been some work, not specifically in the medical field, but probably in a lot of corporations and businesses that's been alluded to, looking at increasing efficiency, you know, specifically for output productivity and things like that. And I don't know, at least what I know now, what has been done in the medical field, but I know people are looking at that. And one group that's been very interested in that has been the trauma surgeons, you know, looking at the trauma data sets, because that is one form of large data that is controlled with very set parameters. So I don't know if this specifically answers your question, but in terms of incorporating AI into the management, not so much of the actual specific trauma itself, but the overall flow of the care of trauma, the utilization, the economy, and hospital uses and loss, you know, things like that. I know they've been looking at that, and that's something that they've been very focused on, because it's, you know, something that's a high burden in a lot of the acute medical care centers. Like I said, I'm not exactly sure if that's actually the question you're asking, but that is one model that we are working on right now with our AI Court Lab. And the question that I think someone else asked to someone else is, you know, how involved do we need to be? And I just want to take this opportunity to jump in a little bit, is I think of AI, maybe not a good metaphor, but it's kind of like your statistician, right? You can have a lot of great data, but if you don't really help the statistician formulate the question that you have in your head, or let's say you don't even specifically know what question you ask, the statistician is just going to do numbers everywhere. It's going to spit out numbers without really having any context. AI is the same way. And so I think, you know, you don't have to be the programmer itself. I completely agree with what everyone has said. But to some degree, it's really the judgment and wisdom of knowing how to apply, and if it's the right question to apply, right? And people joke a lot of times with registry studies, garbage in, garbage out. AI is the same way, garbage in, garbage out.
Yeah, great. So maybe this one is also from Alami, from Oliver's. Can you talk about FDA, SAMD or software as a medical device guideline for maintaining approvals? Maybe Dave, you want to tackle this one?
Sure. So I think there's an interesting effort here, right? In terms of what is the software actually doing? Is it just helping you make a decision, or is it making a decision for you? And I think if you just take that to make it a concise answer, I think that's the real big framework, right? And how do you build that out? And I think that goes into, and I think that changes a lot. I think all these questions are quite frankly interrelated, right? Because if you're making the decision for someone, then and you're removing someone out of the equation, what does that actually mean for your payment model? Are you actually replacing someone? Are you augmenting someone? Or are you just giving someone the data that they need when they need it? Are you enabling them to bill for a telehealth visit while they get the data so they can track your chronic disease progression? And does that speed up overall clinical workflow? There's a lot of also new changes on the reimbursement side and where RPM is being reimbursed. And so if you have RPM that's being reimbursed, that means it is more likely to show up in your EHR. So it means you have more data about the patient. If you have that data, where will we allow that to be more predictive? And will that be more predictive and actually enable lower cost of care? And so will we see more enrollment in Medicare Advantage plans when we see some of these high-risk groups that are now, like dialysis, once again, is a great example of where they went from all being Medicare eligible to all being Medicare Advantage eligible. And I think the cost savings aspect of the payment model is certainly really interesting. So I think it's a pretty interrelated question, but I think it boils down to, do you remove somebody out? Do you actually improve or augment their data? Do you improve that care coordination? Do you save costs? And if you save costs, are they in a some sort of IDN capitated Medicare Advantage model, or are they, if they're in a fee-for-service model? I think it's always going to be a just trickier, quite frankly, a trickier proposition until there's a direct reimbursement for the patients. And last but not least, I'd also encourage looking at some of the changes in the Stark and anti-kickback laws, right? So previously, now, if you're an RPM provider, you can be involved in a preferred relationship with the clinician, with someone that's providing you your atherectomy device. And now I think it's going to be really interesting to figure out how that landscape evolves over the next couple of years. Because if you all have a preferred catheter or device, well, they're going to have to do the tech-enabled services wrapper around that. And is that going to be what you want to see? I've certainly watched and offered enough conferences over the years, being young enough, I think, here to say, watching folks go back and forth about a 1 point incremental improvement and why folks believe that's best and why they're willing to die on that hill. And so I think that'll be interesting to see if that gets taken out of people's hands, because now it's actually about the tech piece rather than the actual device. And it'll be interesting to see where that ends up.
Okay, I would like to ask or send one question to Dr. Lumsden, to Houston. I mean, AI is not just made for large data sets, it depends on large data sets, especially in the early phase of learning. How can we make sure we have a large database available of data that the AI can learn from?
So, I've obviously talked a little bit about, I work in this gigantic medical center where we do 1.5 million imaging studies a year, and I'm sure our neighbors probably do very similar. Why not pull that together? In an ideal world, obviously that's something that should happen. But then it comes down to the question of who owns the imaging data for an individual patient. And are we willing to pool with our competitors? So, I think this is all going to be almost thrown back in Paula's realm, is that how do we start pooling data between multiple institutions? The big imaging companies don't really own individual CAT scans. The hospitals kind of own that, and although you may think it's owned by the patient, but there are huge logistic errors in trying to pool information. I can tell you that our CEO thinks that belongs to us. There was a previous effort at trying to pull tissue samples together. Well, that's not going to happen here either, because we compete with one another. So I don't know the answer to that. I think people like you are certainly throwing out those questions and watching people like me squirm because they don't really have a very good answer for you, because it's the logical thing to do, but not the easy thing to do. So I'm going to throw it back on you, Uwe, and I need your help to try and figure out how we make those arguments that it's the right thing to do.
Okay, thanks. We'll think about it.
That's great. So in the next question, Dr. Bill Shute, for AI to work properly in imaging, do all the imaging study evaluated need to be done in the same way? And where I live, every hospital imaging center seems to have a different protocol for ultrasound, echo, CT, and MR. How do we get around that issue? I'll leave it up to general, either Dr. King, Dr. Lumsden, one of you?
Yeah, sure. I mean, Bill kind of goes straight to the heart of the issue as usual, and you're right. I mean, it's probably more so with MRIs, for example, is that what you see in one institution varies between another, and there's not really a cookie cutter way of everybody performing CAT scans in the same way. And you also know that as soon as you pull that into the PACS viewer, you've got this ability to kind of completely change that, the window, the different levels, and it can look like a completely different CT setup. So yeah, I do think there's going to need to be some sort of standardization in the way that we acquire these images. I understand that the European regulatory bodies are starting to put some of those things together for the imaging companies, but it's a little bit like talking to the different institutions in the medical center. We got to get the Philips and the Toshibas and the Siemens of this world to sit down and agree on what some of those standards are going to be.
That's great. I was just talking to Philip last night about IVUS and AI. So, well, that's wonderful. It looks like we are coming to an end today, and I'd like to thank everybody about the SVS Health IT session at our vascular annual meeting on Saturday, August 21st. at 3 p.m. Pacific time at San Diego Convention Center. So we'll be seeing you guys live. It will be an exciting event for the latest digital technology and innovation by distinguished vascular surgeons. And of course, in the future, we will continue our future SVS Health IT webinar on the topic of innovation, entrepreneurship, and venture capital this fall. So we'll have an official announcement later, coming soon. During the last hour, we learned about artificial intelligence, machine learning, and future digital technology with the impact from the COVID pandemic or affecting your current and future practice. And I truly enjoyed our open discussion about how to take better care of our patients with various digital innovation. So our next step, really, we'll continue to strive for innovation in vascular care. So be well, stay safe, and let's go digital. Have a good night.
Thank you.
Thank you, Dr. Lin, and thank you to all of our attendees and presenters tonight. We now ask you to take a few moments and complete our post-event survey, as your comments will help SVS plan future webinars. Do not close your browser. You'll be directed to the survey questions momentarily.